Imagine going to the doctor with like this chronic burning pelvic pain,
Yeah.
only to be told that it's just, a normal part of getting older.
Right, which happens all the time.
Yeah, exactly. And
Mm.
I imagine you're a 28-year-old new mother,
Right.
right? And you were sitting on that exact same exam table, hearing the exact same dismissal.
It's completely wild, but it's a reality for so many people.
It really is. So today we are bringing you into a deep dive on a very specific, localized biological drought that silently affects millions of people.
Mm.
And we're going to look specifically at what vaginal atrophy actually is and, more importantly, the profound microscopic mechanisms of exactly how it causes such severe dryness and pain.
Yeah, because we are talking about a massive structural and chemical collapse of a localized environment here. And because it's so rarely talked about openly, people just suffer for years.
Yeah.
They're completely unaware that there is this straightforward biological reason for their pain.
Which is why our mission on this deep dive is to demystify all of this for you. We're going to map out the highly effective evidence-based solutions that are actually available right now.
Yes.
And to do this, we are drawing on a really robust stack of clinical guidelines. I mean, we have the latest from the National Institute for Health and Care Excellence, or NICE, along with the British Menopause Society.
And we've got the American Urological Association in there, too.
Right, plus multiple really detailed resources from various NHS trusts.
And I have to say, the clinical data from those sources paints a very clear picture of what is happening at a cellular level and, more importantly, how to actually reverse it.
Okay, let's unpack this, because I noticed right away in the literature that the medical community is moving away from the term vaginal atrophy. They're now calling it genitourinary syndrome of menopause, or GSM.
That's right.
So why the rebrand? And what is actually happening down there to cause this intense dryness?
Well, the shift to genitourinary syndrome of menopause is crucial because vaginal atrophy just doesn't capture the whole picture. I mean, the condition doesn't just affect the vagina.
Oh, really?
No, it affects the entire genitourinary system. So that's the vulva, the vagina, the urethra, and even the base of the bladder. But to understand why the dryness happens, we kind of have to look at the primary fuel source for this entire region.
Okay.
And that fuel is estrogen.
Right, estrogen. I feel like we hear about estrogen constantly, in relation to moods or hot flashes. But what is its specific job locally in that particular tissue?
So estrogen is basically the ultimate structural manager down there. In a healthy, well-estrogenized state, it forces the superficial cells lining the vagina to turn over at this just astonishing rate. We are talking about a complete cellular turnover every 4 hours.
Every 4 hours. That is practically real-time regeneration.
It is.
Like, that's faster than a sunburn peeling.
It's incredibly fast. And this high turnover rate is really the engine of the entire ecosystem. As these cells rapidly die off and are replaced, they burst and they release this substance called glycogen.
Okay.
And you can think of glycogen as basically a localized sugar supply. In this specific environment, it serves as an all-you-can-eat buffet for lactobacilli.
Ah, the lactobacilli. That's the good bacteria we're always told we need more of, right?
Right, exactly. The lactobacilli feast on this glycogen, and as they digest it, they produce lactic acid.
Oh, I see.
And that lactic acid is the key. It keeps the vaginal pH beautifully and protectively acidic, typically under a pH of 5.0.
Which is important because...
Because that acidic shield is completely hostile to bad bacteria and yeast. It essentially soundproofs the environment against infections. And simultaneously, estrogen is also constantly signaling these underlying cells called fibroblasts to pump out collagen and elastin.
Oh, wow.
Yeah, that is what keeps the vaginal wall thick, deeply folded, stretchy, and well lubricated.
Hold on. So if estrogen is essentially the water supply for this whole system, and then you turn off the water, the good bacteria are basically like crops that just starve to death.
Basically, yeah.
I mean, we're talking about a literal, localized biological drought. It isn't just a superficial lack of moisture, like having chapped lips. The ground physically cracks.
What's fascinating here is how accurately that analogy maps to the microscopic reality. I mean, when estrogen drops, the entire assembly line shuts down.
Right.
Those fibroblasts you mentioned, they go completely dormant, the collagen production stops, the tissue actually physically thins out, losing its natural folds, its elasticity, and its physical ability to produce moisture.
And without the moisture and that rapid cellular turnover, there's no glycogen sugar for the good bacteria.
Exactly, which means the lactobacilli starve. And once they die off, the lactic acid just vanishes. The vaginal pH spikes above 5.0, destroying that acidic shield.
Leaving it completely vulnerable.
Yes. It leads to a state of dysbiosis where harmful microbes can suddenly thrive. And the structural breakdown makes the actual walls of the vagina incredibly friable, which is a medical term for fragile. They become prone to microtears from even the absolute slightest friction.
Here's where it gets really interesting. Because society universally assumes this entire ecosystem collapse is strictly a postmenopausal aging issue. Like, it's just something that happens when you're older.
Right, that's the huge assumption.
But based on this stack of medical guidelines, that is a massive misconception. I mean, the data says we're looking at a condition that affects 1 in 4 women before they even hit menopause.
It's true. That is a statistic that usually just shocks people. I mean, it is true that about half of postmenopausal women and up to 70% of women in their 70s experience this.
Sure.
However, the absence of estrogen is the true culprit, regardless of a person's age. So any event that drastically and suddenly lowers estrogen can trigger this exact same ecosystem collapse.
And one of the most surprising triggers mentioned in the research is postpartum breastfeeding. I mean, I always thought postpartum pain was just, the mechanical healing from childbirth.
A lot of people think that.
So how does feeding a baby cause a biological drought in the pelvis?
Well, it comes down to a really fascinating evolutionary mechanism. When a person is breastfeeding, the body ramps up production of a hormone called prolactin to support the milk production.
Okay.
And from a biological standpoint, nature wants to space out pregnancies so the mother can focus on the newborn. To do that, prolactin actively suppresses estrogen, which then stops ovulation.
The body is intentionally flatlining the estrogen.
Yes, exactly. But the side effect of that is that you have an individual who has just gone through the trauma of childbirth, needing their pelvic tissues to heal, but those tissues are suddenly starving for the very hormone required to rebuild collagen and elastin.
Wow.
It induces what is essentially a mini menopause.
That means a 28-year-old nursing mother could be sitting in her doctor's office dealing with the exact same severe tissue fragility, burning, and micro-tearing as a 75-year-old.
Spot on. And unfortunately, because of her age, her pain is incredibly likely to be dismissed by her provider as just, quote-unquote, normal postpartum recovery.
That's just incredibly frustrating.
It is. And the same tragic dismissal happens with patients undergoing medical treatments that steal estrogen, like surgical removal of the ovaries drops estrogen overnight. Certain chemotherapies do the exact same thing.
Oh, right.
And anti-estrogen treatments for breast cancer, like tamoxifen or aromatase inhibitors, I mean, those are designed specifically to starve the body of estrogen to prevent cancer recurrence.
But they also starve the pelvic ecosystem in the process.
Yes, unfortunately.
I want to push back on something, though, because when people talk about menopause, they usually talk about hot flashes and night sweats, and those eventually fade away once the body adjusts, right? Doesn't this localized drought eventually just sort of settle down on its own?
No, it doesn't. And that is a vital rule about GSM that sets it apart from every other menopausal symptom. It is a chronic, progressive condition.
Progressive, so it just keeps getting worse.
Exactly. The ecosystem cannot magically rebuild itself without its primary fuel. If you do not actively treat it, the tissues will not adapt, they will only continue to deteriorate.
Which explains why the symptoms can become so debilitating over time. If the tissue is physically thinning out and tearing like that, what exactly are patients feeling on a day-to-day basis?
The symptoms are really extensive. Vaginal dryness is the most common, reported by up to 93% of patients. But, I mean, calling it dryness almost trivializes it,
Yeah, it sounds like an understatement.
It totally is. Patients describe severe itching, a constant burning sensation, and dyspareunia, which is the medical term for painful intercourse. The friction can be so agonizing and the tissue so fragile that spotting or bleeding actually occurs.
Oh, wow.
And I should definitely note for you listening, any postmenopausal bleeding must always be checked by a doctor just to rule out more serious causes.
Absolutely. I am completely lost on one thing, though. We establish that they changed the name to genitourinary syndrome of menopause, but everything we just described, the thinning, the tearing, the dryness, is happening in the vagina. How does a lack of estrogen in the vagina cause problems with your urinary tract? I mean, those are two completely different plumbing systems for you.
Well, if we connect this to the bigger picture, it really comes down to shared real estate and shared receptors.
Shared real estate.
Yeah. Embryologically, The vagina, the urethra, and the base of the bladder all actually develop from the exact same tissue. Because of that, estrogen receptors heavily line the urethra and the bladder trigone, which is the base of the bladder. So when you lose estrogen, those urinary tissues thin out and lose their elasticity right alongside the vaginal walls.
So the bladder itself is literally getting weaker and thinner.
Yes. And that structural weakening causes urinary urgency, feeling like you just have to pee constantly, waking up multiple times at night to void, and even stress incontinence. But the biggest issue is recurrent urinary tract infections.
Right, UTIs.
Yeah. Remember that acidic shield we talked about?
The lactic acid produced by the good bacteria.
Right. When that shield vanishes, bad bacteria from the gut can easily colonize the vaginal area. And because the urethra is physically very close and is now structurally thinned out and shortened by the lack of estrogen.
Oh, I see where this is going.
Yeah, those bad bacteria have a superhighway straight up into the bladder.
So what does this all mean for someone who keeps getting recurrent UTIs? Like they might be taking antibiotic after antibiotic thinking they just have a weak bladder or incredibly bad luck, but the actual root cause could be this underlying lack of localized estrogen.
In a massive number of cases, yes. Treating the vaginal tissue to restore that acidic shield is very often the secret to stopping the relentless cycle of recurrent UTIs. I mean, it perfectly bridges the gap between gynecology and urology.
It is wild that a vaginal treatment can cure a chronic bladder problem.
It really is.
But considering how painful all of this is, the British Menopause Society actually calls this a silent epidemic. Why on earth are people suffering in silence?
Well, the data shows only about half of individuals actually report these symptoms to their doctors. They assume it is just, normal aging or that their sex life is just over.
That's so sad.
It is. And that silence leads to desperation. People try to fix the dryness themselves, which often makes the microscopic environment significantly worse.
So what kind of DIY fixes are the guidelines warning about here?
Oh, people often use perfumed soaps, bubble baths, or household items like Vaseline to try and find some relief.
Vaseline.
Yeah, and Vaseline is petroleum-based. It actually destroys latex condoms, and it doesn't even absorb to moisturize the tissue.
Oh, no.
Meanwhile, fragrance products, antibacterial wipes, and douches, they act like chemical weapons on whatever fragile pH balance is left down there.
Right.
They strip the remaining moisture and cause massive contact dermatitis, which just drastically worsens the burning.
Okay, hearing all of this, the micro tears, the chronic UTIs, the complete dismissal by doctors, it sounds incredibly bleak.
Yeah.
But you mentioned earlier that the underlying fibroblasts haven't died, they've just gone dormant.
Yes. So how do we safely wake them up and rebuild this ecosystem?
The great news is that GSM is highly treatable.
Yeah.
The clinical guidelines divide the solutions into non-hormonal options and hormonal options. So let's start with non-hormonal, which includes lubricants and moisturizers.
Okay.
And it is important to know they serve entirely different purposes. Lubricants are used strictly at the time of sexual activity to provide short-term relief from friction.
But the sources stress that you have to be really careful with which lubricant you choose, because the American Urological Association guidelines cite a very specific warning from the World Health Organization about the chemistry of these gels.
Yes, they strongly warn about osmolality. Osmolality basically refers to the concentration of particles like sugars and salts in a fluid. The WHO recommends using lubricants with an osmolality of less than 1,200 milliosmoles per kilogram.
Okay, meaning how dense the gel is with extra ingredients?
Exactly that. If a lubricant is hyperosmolar, meaning it's too heavily concentrated, it relies on a basic rule of chemistry. Water always moves toward the higher concentration to dilute it.
Yeah. So if you put a highly concentrated gel into the vagina, it will actually suck water out of the vaginal cells to balance things out.
Wait, so a product you're buying specifically to add moisture to your body can paradoxically dehydrate your cells even further.
It can completely dehydrate them, which causes the cells to shrivel and die, and that leads to even more irritation and susceptibility to infection. That is why it is vital to avoid the heavily flavored, warming, or highly concentrated gels. You really just want to keep it simple and check the osmolality.
That is such a vital piece of consumer knowledge right there. And what about moisturizers? How are they different from lubricants?
Well, moisturizers are used for ongoing symptom management, usually 2 to 4 times a week, completely independent of sexual activity. And the most effective ones are bioadhesive.
Bioadhesive, meaning what?
This means they physically attach to the mucin and epithelial cells on the vaginal wall.
Hold on, let me stop you there. Epithelial cells. Are we just talking about the surface skin layer inside the vagina? And what is mucin?
Spot on. Epithelial cells are the barrier cells lining the surface, and mucin is the main protein component of the natural mucus they secrete.
Got it.
So bioadhesive moisturizers lock onto those surface layers and they hold water against the tissue for days. They also contain ingredients that actively lower the vaginal pH back toward that healthy acidic level, which helps keep infections at bay.
Okay, that sounds great for immediate symptom relief. But if you want to truly rebuild the ecosystem, like to wake up the factory and get the body making its own collagen again, the clinical guidelines point to a gold standard.
They do. The definitive gold standard is local vaginal estrogen. This is a prescription medication delivered directly to the vaginal tissue via a cream, small dissolving pessaries, or a flexible ring that stays in place for 3 months.
Okay.
And it literally reverses the condition. By reintroducing the fuel locally, it replenishes the glycogen, it brings back the lactobacilli, thickens the skin, restores the blood flow, and even plumps up the bladder lining.
So what does this all mean for someone who is completely terrified of hormones? Because I feel like a lot of people hear the word estrogen and they immediately panic.
I absolutely do.
They think about the scary headlines from 20 years ago regarding systemic hormone replacement therapy, and they worry about massive systemic risks like blood clots, strokes, or breast cancer. Is it accurate to say this local treatment is the equivalent of, like, rubbing a hydrating lotion onto dry hands rather than swallowing a pill that alters your entire body chemistry?
This raises an important question, and your analogy of hand lotion is the perfect way to look at it. Systemic HRT-like pills or high-dose patches circulates estrogen throughout your entire bloodstream to treat whole-body symptoms like hot flashes.
Right.
Local vaginal estrogen is a microdose. It is designed to stay almost entirely within the localized pelvic tissue.
So it's not flooding the bloodstream.
No, not at all. The systemic absorption is negligible. Because it bypasses the bloodstream in any significant quantity, it does not carry the same risks as systemic HRT. The guidelines from NICE and the British Menopause Society confirm it is incredibly safe for long-term use.
That's huge.
It is. In fact, even for many breast cancer survivors, local estrogen can be a safe option after a shared decision-making discussion with their oncologist.
I think that distinction will be a massive relief for so many people listening. And if local estrogen isn't the right fit, the guidelines do mention a couple of other newer prescription therapies too, right?
They do. There is a nightly vaginal insert called prasterone, which contains DHEA.
What's DHEA?
DHEA is a precursor hormone. You insert it, and the vaginal cells absorb it and actually convert it locally into both estrogen and testosterone right inside the cell. It is shown to be highly effective specifically for pain with intercourse.
Oh, interesting.
Yeah, and there's also an oral non-estrogen tablet called ospemifene. It is a selective estrogen receptor modulator, meaning it mimics the beneficial effects of estrogen specifically on the vaginal tissue, but it actively avoids stimulating breast tissue.
I want to pivot and push back on one other treatment that is heavily marketed right now, because you see ads everywhere for vaginal lasers, like the Mona Lisa Touch, promising vaginal rejuvenation.
Oh, yes, the lasers.
Right. If I am looking at a brochure in a med spa window, it sounds like a miracle cure. But what do the actual clinical guidelines say about blasting this delicate tissue with a laser?
The clinical guidelines urge extreme caution. NICE currently states that there is inadequate evidence regarding the long-term safety and efficacy of these energy-based laser treatments for GSM.
But if there's inadequate evidence, why am I seeing them marketed everywhere? Like, what is the laser actually doing to the tissue that makes the medical community so nervous to recommend it?
Well, the theory behind the laser is to intentionally create microscopic thermal trauma to the vaginal walls.
Thermal trauma.
Yeah. The idea is that this injury will force the body to rush blood flow to the area and stimulate those dormant fibroblasts to produce collagen to heal the burn.
Wait, so you are basically burning the tissue to trick it into healing itself?
Essentially, yes. But the problem is, the marketing has far outpaced the science. When researchers conduct randomized controlled trials comparing the laser to a sham treatment, basically a placebo laser, or to simply replacing the missing local estrogen, the evidence just isn't robust enough yet.
Interesting.
Yeah, it doesn't prove it works better, or that it is safe to repeatedly burn tissue that is already paper-thin and fragile. Therefore, the current recommendation is that they should only be used in the context of controlled clinical research, not as a standard out-of-pocket fix at a spa.
It is always wild to see where the marketing hype completely separates from the actual medical consensus.
It happens so often.
So, to summarize where we are for you, vaginal dryness, painful sex, and recurrent urinary tract infections caused by GSM are not personal failings.
No, not at all.
They aren't just an inevitable part of getting older or a normal postpartum struggle you just have to grit your teeth through. They are the direct result of profound mechanical and chemical changes to a localized biological ecosystem that has simply lost its primary fuel.
And most importantly, it is a highly, highly treatable condition. No one should feel they have to silently accept progressive pain and tissue deterioration when we understand exactly how the mechanism works and exactly how to reverse it.
Whether you are using this information for yourself or maybe sharing it with a partner, your mother, or a friend who just had a baby and is wondering why she is in so much pain, having this knowledge means you don't have to accept pain as a default state. You can confidently advocate for the precise moisture and medicine that your ecosystem needs to thrive again.
It is all about restoring the environment so the body can go back to doing what it does best, which is protecting and maintaining itself.
And, that leaves us with one final provocative thought for you to just sort of mull over. We learned today that those vital fibroblasts, the cellular factories responsible for keeping the tissue elastic and collagen-rich, they don't actually die when estrogen disappears. They just go dormant.
Right.
So as medical science continues to advance rapidly into the realms of targeted cellular and gene therapies, could we eventually discover a way to locally wake up those dormant fibroblasts without needing to introduce hormones or precursor hormones at all?
That would be amazing.
Could we one day cure vaginal atrophy by simply hacking the tissue's own biological memory, reminding the desert exactly how to be a garden again? Something to think about. Thanks for joining us on this deep dive.